Welcome to The Doctors Are In. So this is a monthly sort of talk show style conversation between a PhD, someone in the humanities like myself, and someone from the medical profession, so a medical doctor. And those are the doctors who are in. And we have conversations about themes that transect our work. And it's all about generating and fostering an atmosphere of interdisciplinary collaboration. So our topic today is disability studies in medical settings. I suppose I should start by introducing myself. My name is Marion Quirici, and I'm a lecturing fellow in the Thompson Writing Program, also co-director of the Health Humanities Lab, and I'm the faculty advisor of Duke Disability Alliance, which is a student organization for students with disabilities and their allies, and they're working to make the campus a more accessible and inclusive space. I also run an interdisciplinary faculty working group called the Disability and Access Initiative, which is for faculty who work on disability topics really across the disciplines. So we have people from all across the university, including Christopher, who's one of our newer members. So I thought I would start by giving some context for what the field of disability studies is. So disability studies has origins in disability rights activism, and one of the foundational ideas of this discipline was the creation of something they call the social model of disability, which exists basically as an alternative to the medical model of disability. So while the medical model it defines disability as a sort of individual hardship and addresses it on an individual level, something requiring care and or cure or rehabilitation. The social model rather looks at the ways that the environment creates disability, right? The ways that unaccepting social attitudes might be disabling, the ways that stairs and the built environment might be disabling if you have something like a mobility impairment. And so the social model is really empowering because it enables coalition amongst people with different kinds of disabilities, right? So while there might not be similarities in the way someone who uses a wheelchair experiences the world compared to somebody who is blind, right? They do share similar experiences of exclusion in an ableist world, right? Or a world that's built with a sort of normative body in mind. So disability studies really helps us to destabilize those concepts of normalcy. A lot of the scholarship in the field is about how our ideas of normalcy are socially constructed, and it's kind of based on a fiction, right? There's nobody who's perfectly normal in every way anywhere in the world, right? So once we realize that that's a fiction, it's sort of like, well, what norm are we pushing people towards, right, if that's a fiction? And so part of this is, so creating an alternative social model, it's really important to still talk to the professionals in medical settings, right? Obviously, humans need healthcare, right? We're not saying we need to get rid of medicine. So how do we integrate? How do we collaborate across that divide? And so that's part of what my faculty group, the Disability and Access Initiative, is trying to do here at Duke. And someone like Christopher, who is situated in medicine and yet is also deeply involved and interested in disability studies, you have things to share with us. We have things to share with you. And so that's the importance of having these conversations. So Christopher, why don't you tell us a little bit about yourself and your work in medicine and your work in disability studies.
Perfect. Well, thanks first of all for having me, and especially thank you, Marion. Thank you to the HHL. Thank you, Tuki, for organizing everything. This is, I think, really important for all of us to take a time to look at that divide that you said, and it's a divide that I wasn't really aware of until I finished my medical training, and that's despite being a doctor with a disability myself. So I am a fairly new recruit to Duke. I did my medical school at UNC and then a lot of my training at University of Virginia in Pittsburgh before practicing for the last several years at University of Virginia, and I just came back this summer. And I am a pediatric physical medicine and rehab doctor. So that is a very rare field, but the way to kind of conceptualize it is you have your neurologist who understands the nervous system, your orthopedist who understands the musculoskeletal and can do surgery if needed, and then you have your rehab doctor who understands neuromuscular systems but does not do surgery and adds a new facet of functional understanding of what the body can do. And so, and I do that for, I've learned to do that for adults, and then I went to fellowship to be able to do that for kids. And then now I co-direct our cerebral palsy or cerebral palsy clinic here at Duke, and I do a procedure that's a procedure with the botulinum toxin or Botox, which is the same thing for wrinkles, that helps actually some kids with overly tight muscles obtain new range of motion and new functional abilities. The thing I think you should already start to hear is I keep talking about ability, function. This is a part of my discipline of medicine, which is a little bit different of a discipline. And it starts to break down a little bit this very strong center that we built medicine around of the cure. You talk, so in their world, they would maybe talk about medical versus social. And then I go further to say, that we've been focusing on curative medicine and really getting away from therapeutic medicine, which any therapist in the room would tell you that that's also always been there. But the doctors and the training that the doctors get is usually very, very light in understanding when they need help in that realm, what to prescribe, how they can be helpful to a team and a plan that does that. And so the good and the bad is that I don't want any child to need my services. If they need my services, that means that there are things that in this realm of neurodiversity or normal development that they are struggling in some way. And yet, I would hate for them to be struggling without someone who understands the functional side of what they're dealing with, because there's no cure most of the time. And since there's no cure, these families get very frustrated and they're very vulnerable and they're very scared to a world of every single person on the internet trying to tell them that they should fly to Europe to go get some treatment or do something, again, looking for a curative thing when there's still a lot of benefit to looking at a therapeutic model. I think the only other thing I would say is that kind of getting back to how I found more about disability studies. So at University of Virginia, we have a disability studies program. We got a minor. Christopher Lunsford is a friend of mine who started that minor there. And he also has a every other year disability studies symposium. And I kind of sort of invited myself the first year, and I found out that part of my medical group had offered to sponsor his symposium. And his group had to respectfully decline the sponsorship. And the reason was for the population and the audience they hoped to reach, they were very scared that if a medical side of a university was sponsoring it, it would immediately signal other people that that wasn't talks they wanted to be at. And that struck me to my core. It told me that something is very wrong about the conversations we're trying to have, that it would change the outcome of an audience that people would show up to a discussion about. And so ever since then, I've been learning more and working with him more. And so tonight we're going to talk about a lot of these exciting things about the divide. So where should we start?
Well, something you just said that really struck me was the distinction between curative medicine and therapeutic models of medicine. And I think there's a lot underneath that divide. And in disability studies circles, there are a lot of complex feelings around cure, right? And it often falls along cultural lines. One example that I often talk about with my students who are first-year students in writing courses is in deaf culture, the question of cochlear implants, right? So these are a device that you can get before the age of 4, I think. You have to be quite
Actually,
young.
all the way up to age 90,
you
95.
You can get them older now?
Yeah,
okay.
you can get them during your whole life.
Okay. And typically it's...
The criteria change.
Yeah. Yeah. And so the conversation around seeing cochlear implant as a form of cure, people within deaf culture for whom this is a language, it's a culture, they don't want to lose that language and they don't want to lose that culture. They want their children to have the same experience of the world that they have. And so for some people this becomes an ethical question of like, do you get your child a cochlear implant, make them hearing, or not? And is it ethical to do that? Is it ethical to not do that? And so I think a lot of times the cure debate is around culture. And historically, in earlier days of the social model of disability, there was a very anti-cure feeling, right? Because like, I think we have to think about the harm that can do. The idea that you need a cure might imply that there's something wrong with you, you're broken, you need fixing. And that in itself can be really pathologizing, right? And experiencing that being pathologized can create trauma in itself, and that creates new pathologies, right? So it becomes this spiral. But of course, there's a lot of good that medicine can do in terms of like the quality of life, improving autonomy, etc. And so I think a lot of people with disabilities are saying, well, actually, I don't want to be stigmatized because I want cure, or I don't want to be stigmatized because I want to engage with psychiatry, or I want to engage with medicine. So it's having to become a more nuanced conversation. The cure debate within the neurodiversity movement is something I thought we should linger on. You mentioned the word neurodiversity, but I'm not sure everyone here will have heard that concept before. So essentially, neurodiversity is about recognizing that our minds have diversity, right? And that we should value that diversity as much as we value biodiversity, right? And not necessarily see something like autism as necessarily being a deficit. It's rather a more complex configuration of abilities and disabilities, right? And so within the neurodiversity movement, advocates...
Or even ADHD, I think is a good mental exercise. ADHD has been so set outside of the norm because it's hard to have an ADHD kid in our current public school education system.
Exactly.
Not because they can't be amazingly creative.
Right.
And so again, sorry to kind of cut you off. It's just
100%.
another example.
I'm glad you brought that up because that shows a lot of the ways in which certain differences, disabilities are socially determined. It's sort of like what environment are you in and what behaviors are expected in that environment. And so that becomes what defines you as disabled rather than anything about your mind or about your body. So when neurodiversity advocates feel offended by the idea that autism should be cured, they're against this idea of a world without autism, right? Or this idea that autism is this evil thing. It was represented by various organizations as being like, you know, something that comes in and kidnaps your child and puts a changeling in its place, or just a lot of really negative and stigmatizing, I guess it was advocacy, but in a really bad way. So they felt really offended by that cure model, that feeling of like, you shouldn't exist, people like you shouldn't exist. But that doesn't mean that they feel like they don't have challenges as a result of their autism, right? And that they don't want to figure out ways to ameliorate those challenges. I'm really glad that you brought up the cure debate. I'm just sort of thinking about how we can think about ameliorating those challenges, not just by fixing or changing the person, but also by thinking about our environment and our social attitudes and the ways that we view difference, and intervening there as well. Yeah,
I think I would like to ask the question of the audience to see if anyone, we would love for you guys to participate early and often. So, so in this question, I really want you to think to yourself, why do I go to a doctor? What is it that I want from a physician and the impact that I want from that person on my life? And no one says the answer is to change my personality or to change my social network or to change my job prospects unless they see me, because I'm trying to help them for the better. But it's such an interesting question because it's one that people haven't really allowed themselves to think about that much. And does anyone have a thought on that? What do you want from healthcare? What do you want if money were no object, what do you want from healthcare?
A knowledgeable dialogue, which doesn't happen very often. We're often proselytized to, or we aren't included. The doctor doesn't start the conversation with, what do you want? Why are you here?
Yeah.
That's the biggest problem.
Yeah.
I can name so many times in my family, anywhere from my schizophrenic sister to my bipolar mother to somebody who lost the ability to swallow and is on a G-tube, to me with my blindness, and I was told not to have children. I can name a billion things, but nobody asked what we wanted.
Yeah, I think that's such an important part of medicine that somehow got lost. People have changed. So I start every conversation with the family with, what are your goals today, not knowing sometimes why they even kept the appointment, because I'll get referrals that really just say, you need to go. And the family will say, I came because I was told to come. But everything else in between is, medicine started this model of teaching that we want to help by addressing the thing that's most important on the person's mind that day, but then they called it the chief complaint. So patients are complainers, and they need to come and tell us only one complaint, and we will help them with that one complaint, and then we will turn them around and say, come back tomorrow if you have a second complaint. How awful is that? But that is what medical students are being taught as we speak at this institution. So it doesn't leave a lot of extra time in there to say, well, I don't really necessarily have a complaint. I wanted to learn more about my body and how it functions and things I'm experiencing. So where is that in medicine? Where have we lost that? How do we get back to that? In my question, because no medical student started medical school saying, I want to help people one complaint at a time.
Yeah. So that's another thing I think disability studies kind of can give us. So there's the notion of the idea of structural competency, which is analyzing all of the broader structures at play with something like this. So I'm thinking about like the way that medicine is structured, the questions that doctors are supposed to ask. One thing that always comes up on my visit notes after I go to the doctor is I can see that the doctor had to answer the question, did you talk to the patient about their weight and like their fitness and the importance of strength training and stuff like that? They always say like, yes, I talked to her about her workout, routine, and it's just sort of interesting that that's there, but not so much of the like, what do you want to get out of this? And it's not so much about your wellness. For example, if you try to get a specialist visit, they ask you what like diagnosis you have that falls under that specialty, not like you might be wanting to go in to an endocrinologist to learn more about your hormonal systems and how to manage that, but you can't unless you have a disorder that falls under that category. You can't even go to that doctor. So these are all like systematic things, and then there's the whole issue of health insurance and the ways that health insurance companies are they have this incredible power to actually make decisions about what lives are worth living. Who's going to get the resources that they need for life-sustaining treatment.
And big pharma together. So that's a really interesting, mutually beneficial dichotomy for them and no one else.
Yeah. So just structural competency, I guess, is what I wanted to put on the table there. What ways do you see that playing out in your practice? I mean, for me, I've only seen it from the patient side. So
I would say there are two big questions. One is the structural competency of the role of big pharma in the U.S. and the insurance is a little bit separate, because I don't have the training to even speak to how we can chip away at the conversations that they are having between a pharmaceutical and an insurance company. That means more than the conversations that a doctor and a patient is having. I mean, that is determining lives much more. Of the conversations that are happening between doctors and patients, and I can speak to that, and the structural, I have to admit, I don't know the structural competency enough to speak exactly to it, but what I would say is I kind of get back to what do we capture and where is the value of this relationship, and how can we still allow the doctor to provide information that he or she feels like is needed information about the strength training or the weight maintenance as it relates to health, but also not provide it in such a way that it is so paternalistic that it doesn't even help. And so again, it does, I think when you just say, I have to say this to check this box off, that is some of the least effective counseling that you can imagine. So my question then goes back to, so we made the doctor say that so they get the appropriate level of payment for the time they spent with the patient. And yet we then still missed, did it have the effect, the intended effect, which was a chance to have a real conversation about an aspect of health.
Yeah. I feel like this is something we can also open up to the whole group. So you were talking about the inherent paternalism of some of these conversations, and I think one of the things that we learned from disability studies is how to analyze the power relationship that's inherent in the doctor-patient relationship. And how, I guess people here could comment on how they see that operating when they visit the doctor. How do you feel disempowered in that relationship? Have you ever felt empowered in that relationship? Because that could be an example of something that we could learn from, right? So yeah, do people have comments on that? Just the power differential? Yeah, Barbara.
A friend of mine who was being treated for a rare cancer was determined not to be put in a less than a collaborative relationship with her cancer carers. So she was very careful every visit to pick out a particular wardrobe, and she refused to see her physicians in a gown. And she also, even when she had to do surgery and overnight, she refused to be in hospital attire because she believed that was one of the artifacts that propelled the dynamic of the power dynamic. So she, it was really interesting to watch her go through a very long process of not only needing to be concerned about her health condition, but very intentionally taking steps to guard against that. And it's a shame that that much energy has to go into being treated as a partner in care, but she was very intentional about it.
What was her result? Did she feel like it had the intended effect?
She had a very good relationship with folks who first started out kind of up here. So I believe that she would say it did have an effect because there was but of course it was long term, so that might happen anyway. But there was a relationship, not just a treatment.
Yes.
I had Crohn's disease, and I had a medical emergency, went to an ER. And by the time I arrived at that point in my life and in my illness, I had learned a lot of medical speak. And so when I was describing my symptoms to the resident who was examining me in the ER, I was using language that was in the chart. And everybody on the team who was taking care of me really did not talk down to me. It was like a professional to professional. I had just graduated from undergrad in nothing resembling medical anything. And as they were getting ready to admit me, they said, "Where are you a resident?" But so I did that because I was able to maintain a lot of autonomy. I had people take my pain seriously. I had people take my symptoms seriously because I was speaking their native language, but not mine. And what happened was what it meant to me and how I felt emotionally, and that part of me that really desperately needed care, as well as the physical part of me, was silenced completely. And so my subsequent care was that social worker didn't see me. Nobody said, "How are you feeling without this?" Everybody treated me like they were talking to a colleague and like, "You've got this," which in some ways was very beneficial, and in some ways left the humanity out, but got me very good care mechanically.
Yeah, I mean that sounds like
you deserve both.
I mean, so both of these stories kind of required a lot of extra effort on the patient part that I think the majority of people don't have, don't make, or they don't have the facility with the medical language that you had in your example.
And it can't be the requirement. That can't be how to fix things.
Exactly. It's sort of how can we have the language of medicine be more accessible for the majority of people? Yeah.
I find what you're saying just so fascinating as somebody who studies language, because the issue here is one where you've got a complete opposition between what we know is true of the medical situation and what we know is right for human beings. And it gets to what the word conversation means. Because when you think of it, we really think of only two ways of talking, monologue and dialogue. And monologue can be, or has to be usually, goal-directed, and the person that gets to set the goal is the speaker. And dialogue, if it's true conversation, there's no goal. When we have a true conversation, we make it up as we go, and we get to wherever we get to. But the medical doctor, on the other hand, has been told that he or she has to provide something, and so they have to have that goal. And so having a real conversation, and there are all sorts of dialogues that aren't conversations. Start with the Socratic dialogue. It's not a conversation.
Talking points.
Socrates knows where we're going to end up. It's just a matter of how long until we get there. But real conversations, and I find the same thing. I have quite a few doctors in my life now. I had a doctor's appointment today, which is why I'm here. And when you go in talking their language, and he said, how many people come in wearing a tie? I said, well, I was going to a presentation this afternoon, but I didn't say, I probably would have done it anyway. Because I do tend, I don't go in sweatclothes.
This is all really fascinating. My background is in English, and I teach writing courses, and so language is always the first order of business in my courses. And obviously there's the doctor's language, right? The medical language and terminology that you see in your chart, and most of us don't know what it means when we encounter it. And then there's accessible or plain language, but then there are some people whose access to language is completely different, right? If you're nonverbal, or if you have verbal processing issues. And I think that language is one of the key tools for accessing power, right? Our use of language is how people perceive us as agents or as people who have power. And so with the neurodiversity movement, with like mental illness, if you have those labels, sometimes that in itself is enough to deny you of your personhood, right? Or to say that, okay, because there's this label on you, if it's schizophrenia or something like that, which is very deeply stigmatized in our culture, then people just don't take count of anything you say, right? And particularly in medical settings, it's sort of like, oh, well, this is just a symptom of their disorder. And so that is the most incredibly disempowering thing I think a person can experience. So, yes?
Since you're an English professor, there's a great example of someone using language very powerfully. If you go back 20 years to Reynolds Price, Duke's most famous English professor who wrote the book, A Whole New Life, An Illness and a Healing. And did anybody read that? Yeah, because basically he was seen staggering around campus, and they assumed he was just another drunk English professor.
Just another, because there's so many of those.
It's Southern tradition, actually. And it turns out he had a spinal cord tumor from the base of his skull the whole way to his lower back.
Right.
And the most powerful part of the book is when he describes his encounters with Duke physicians.
Really?
Oh, yeah. I mean, Alan Friedman was his neurosurgeon, and he glowing response about Alan all over the book. When he got the radiation therapy, it was Dr. X. And we all knew who that was, but he said, should have a button that says, technically competent but inadequate to deal with human beings. And this is in the book, so
Yeah.
It's powerful. And he does also go through the whole process of being totally disempowered by the medical system and being 10 out of 10 pain, cannot function, and is really severely disabled in a wheelchair and paralyzed.
Yeah.
But he winds up asking Alan in the last depths of his despair, is there something else I can do? And Alan says, well, you can go talk to Pat Logue. He's in the depths of the psychiatry department somewhere, where he does hypnosis and biofeedback, and sure enough, totally transformed his whole experience. And he went back to being a prolific writer that he always was.
Wow. Over here?
I think language is one thing, but also time is another thing. When you've got such limited time, typically it's about 15, 20 minutes.
Yeah, you feel like your doctor has somewhere they have to be.
Yeah, exactly. Like we were just saying, it's goal-oriented, right? They want to, it's leading to somewhere. They've only got such a limited amount of time. How do you really interact with the patient? I think that time constraint in and of itself, with or without the language, although the language issue is definitely a problem, it's like a huge
Yeah.
I'll speak to that in a little bit, which is there is a really fascinating thing that has happened to make medicine a business that doesn't seem like a business, but yet it seems like a business. So when you see your lawyer does not at all make you feel like you're wasting his time at all. Because later on, you're going to get a bill that says exactly how much time you took of that lawyer's time,
6 minutes.
and to the minute. When you see your doctor, we don't do that because we wouldn't dare want you to feel like it's a business transaction. And when we say we, I mean the system. And yet then the backside is that it's still a business transaction, and the doctor gets repetitively pummeled if they're not staying on track, if they're making the next patient wait, if they're not producing the right numbers for their day. So somewhere we've missed this, are we going to pay for it or are we not going to pay for it? Which is, I spend an hour with my family when they're a new patient, and I regularly go over to 80 minutes if we need to, and I have buffer zone built in for that. And that's because I might see an 8-year-old, but that's 8 years of rehabilitative medicine that I have to consume and give thoughts on in that time, and then prepare a plan for at least usually 6 months because they drove 3 to 4 hours to see me, and then get ready to see them again and know that that plan went somewhere. And that's still cutting it close. And so, and the funny part is that I have to fight tooth and nail to get that time. I have to pretty much tell them, I don't care if you don't give me bonuses. I don't care. I will not accept less than this time to take that position. And that's not something other doctors have the knowledge, gumption, willpower, understanding to do when they probably still should. Because a 52-year-old with high blood pressure and diabetes is also very complicated. Even though we like to think that it's not, it always is. And I say we, meaning that we've gotten the algorithms down to where if we ask just the right number of 10 questions, we'll know what to do for the next 3 months for that. But then what has this become? It's become a coding algorithm. Where did we lose the conversation and the humanity?
Yeah.
And I've had people tell me, I've been thinking, okay, what if we just code it in a different way? And there's a coding system that I love called the International Classification of Disability, Functioning, and Health. It's from the World Health Organization. It could be really transformative in changing how we bill for certain things to capture function. But then it's still coding. I told a patient friend of this about this, and she looked at me and she said, so what? You're still coding me. And I know you're coding me as you're talking to me. I don't want families to feel like that.
You're coding me as you talk to me.
Yeah.
That's really interesting. And that just like, as you were speaking about that story, it made me think about how structural competency isn't just about like analyzing the structures behind medicine, but it's also analyzing the structures behind the patient's lives and what might be contributing to their experience of illness or wellness. And so are there ways to kind of increase doctors' empathy in order to understand all of those structures? And I think you can't just make it about the doctors increasing their empathy. It also has to be about like, how can we cultivate the time, right? So to actually have a conversation that gets at all of that complexity and that gets at the humanity. And so it has to be both, right? It has to be about the doctors, but it also has to be about the system, and I think changing the system.
And maybe just maintaining empathy. I mean, you'll never see a more empathic group of people than a set of first-year medical students. You just won't. And somewhere along the way, it gets beat out of them.
Yeah.
So, and I know where, but I won't get into it. But that
I actually want to know.
Well, let's take this question, or I'll just say it really comes down to, again, feeling like you're a cog in the wheel.
Yeah.
So as you go through residency, medical school, and then residency, which is where you have to do 4 years of training to learn the medicine, and then at least usually 3 to 4 years to practice under direct supervision. But that 3 to 4 years of practice under direct supervision is also used to absolutely increase the efficiency of the people you're practicing under. And so much so that by the end of that, you can't help but be jaded, because when you're waking up at 2 a.m. so that someone else can sleep and make more money off of your work, you begin to see, you don't see people as people, you see them as TPS reports from the office space, which is this, where you're just trying to churn through as many things as possible, and that's when you start to let people lose their personhood.
Yeah. Wow. It sounds like definitely a labor issue as well.
It certainly is.
Absolutely. Is there a question? Yeah.
So I want to preclude this by saying I got his permission to tell this story because I want to talk about him first. He's been out of the hospital about 5 weeks now. He went in for a stroke recently. It's not the first go-round, and he has an odd genetic family problem. But bottom line is, I think it's critical that people go in with advocates. If you can't speak for yourself, what's really odd is that I have a disability and I'm an advocate and I do medical speak. So that's kind of interesting. But what happened was, I think the doctors, I observed that they were empathetic to a certain extent, but the sort of Damocles is held over the head by policymakers and systems. So his situation, just to speed things ahead, was his stroke affected an already compromised swallowing capability, which we're now looking at a G-tube anyway. So the policy at Duke is not to put G-tubes in on the weekends because they have a nominal staff. Only trauma surgeons are on staff. And here we are standing in the Duke Medicine, we're standing in the pavilion, floor to ceiling glass and marble floors. And they're telling us they don't have the money to pay for surgeons to do. So they're going to keep him alive for now, going on 7 days on sugar and water. And I said, they did that in Auschwitz to people. This is not humane. He could be out of here. He needs the G-tube. This is what we find. He can walk. And the other thing is they're shooting him full of blood thinners. He's perfectly capable of walking, by the way, because they felt he would develop clots because of liability. So I'm like, I want to get him up out of bed. They won't let me walk with him, and they have a lack of staff, so they'd rather shoot you with blood thinners. All said and done, I basically threatened that I would own the pavilion if he died. And they did. They put the tube in, but it was so uncomfortable and so horrible and so horrifying and so upsetting. I got sick at the end. I'm the one that got sick. He got out eventually, but I sort of like, you know, I was like post-traumatic for me. I guess my point is, I met with the chief of operations and administration, and she was hardcore. I mean, I said, look at where we're standing. You can't tell me that Duke doesn't have enough money. They certainly have enough students and residents here to have surgery on weekends. Why do we have a nominal staff? They couldn't answer, and they refused to answer.
I can answer it.
Thank you, please.
It's because it's like saying, why can't I meet with the lawyer on the weekend? The lawyer wants his weekend off. All the people who have the training to do that are not on call for anything other than life-saving procedures on the weekend.
You're telling me they don't have surgeons available?
Oh, they do, but they're on the golf course. They're on the golf course. And so they don't.
I disagree with you. I'm sorry.
Oh, no.
I believe there are plenty of doctors who would love to take on weekend hours in exchange for having weekdays off.
For that procedure, no, because it doesn't pay.
General surgeries, they said any surgery other than trauma is backburnered. It's considered a, what do they call it, a voluntary surgery.
Yeah, elective. They didn't tell you a lie.
Elective, right,
Yeah, they didn't tell you a lie.
It wasn't elective.
And by that's where the meaning of words. What's the definition of elective? What's the definition of medically necessary? They
The moneymakers decided it.
well, that plus they made more money with you staying on the weekend.
Oof.
So it's a false decision in the first place, which is they don't have any incentive to get you out on a Friday night when they can just as easily put in an elective G-tube, elective by the nature of life-saving G-tube on a Monday morning. The system, it's a business. Pretend like you're talking to the shrewdest car salesman that you can imagine, and that's every single hospital in this country.
I think it's even worse than people realize. I'm a healthcare worker as well, and I think even for some physicians, they have no idea how. Patient care at the bedside is really catastrophic for patients, for advocates, and it's not because of always lack of empathy. I think most healthcare workers really do want to do a good job. I'd say for me, my experience has been more systemic, and your hands are tied. It's like you're in a fight and you've got both your arms tied behind your back. And I can definitely empathize with your situation. I actually work weekends.
Yeah.
And I know we're short-staffed, but not because we don't have the funds or the resources available. It's just because the hospital says it.
Well, are they into real estate or people? That was the big question. It's been discussed before at the disability conference. The first thing that came up is somebody said they looked at Duke per se from a standpoint as an incoming student with a disability, and there were pictures. Most campuses have people of all colors and creeds and disabilities, and everything's on there. Duke only had architecture, and he said, "Is this a real estate company?" I mean, really, I could understand, but standing in that building, it made me feel like, wait a minute, where are your priorities?
I'll say this too. I was at a conference for Medicare for All this past weekend, Medicare for All, but they put up a slide, and it's just happened to be Duke, but it could be probably any other hospital in the country. But they had two stats. There was one saying that Duke has 957 beds, and then they have 1,600 billing clerks. So it's two billing clerks, or 1.5, I guess, per bed. It's pretty shocking. So I think we're all kind of saying the same thing, which is
What can be done?
It's all circling back to themes of power, themes of profit in healthcare, as though it's a business, as you called it, and
Undercurrents that cannot be denied.
so
I'm
yeah.
curious if you could speak to the role of technology in these conversations and these relationships, if that impacts it positively or negatively.
Technology is a really big topic, and there's so many ways that technology provides is life-saving, right? I would say what's forefront in my mind right now when I think about healthcare systems and technology is a story I read in the news last week in the UK about a woman with I can't remember exactly what her disability was, but she required around the clock care. And overnight care so that she could use the restroom, etc. And as a cost-saving measure, her overnight carers were replaced with a camera that would watch her overnight, and some remote healthcare person would watch on the TV screens her and multiple other people to see if there were signs of distress. And if there were signs of distress, then someone might rush over, right? But so that really limited her independence. Her family was deeply concerned. They felt like, okay, now we have to go and do the round-the-clock thing that she used to get. So I think that you have to be cautious against letting technology do too much, and there are certain things that you can't replace human-on-human contact. Mm-hmm. So I don't know if you have thoughts about technology.
Well, and I have
it's
more thoughts
than
we have time to cover here, and so I want to try to hone in on technology that I experience that may impact disability. And so the main issue becomes that there are technologies that are just as important to quality of life as any medicine you can imagine, any therapeutic plan you can imagine. And for example, I wear hearing aids, obviously, and without the hearing aids, I could not be a physician. Is that probably a good thing? I don't know. Because again, it's again one of those things where you have to figure out what role is technology going to play in someone's life. So you have something like a cane that can play a role in someone's life. Later on, someone may develop an exoskeleton that is $1,000 to $10,000 more expensive than the cane, and there will start to be studies to show that that's $1,000 to $10,000 more helpful to that person's walking health for their whole life compared to the cane. Mm-hmm. Or will it? Because you're still putting on a device. You're changing the nature of how you get ready for the day. You're getting to the point where a person could be happy with a cane and not need to be sold a $100,000 exoskeleton, because we're close to those kinds of things. So the question has to become what is medical necessity of technology, and we're nowhere close to having even a good idea of how to have that conversation. And this relates directly to work I've done with my father, who is a linguist and who's in the room and sitting right here. And we've looked at the meaning of medical necessity as it affects outcomes and who gets to define the power of medical necessity, because that's fascinating. And I just think in the next 50 years, we're in for a huge revolution on medicine about what technology can do, because the number of things that we do in a high iteration now. We've been using the same types of power wheelchairs for 30 years. In the future, the features on power wheelchairs will change faster than the features on cars. And then you're going to have to figure out what are we paying for that? What are we not paying for that? What does that do to help someone's quality of life? And I think that we're in a big trouble because we don't even have a foundation for how to describe that medical necessity.
Yeah, there's a really good documentary that you should watch on this called Fixed, the science/fiction of human enhancement. And it talks about the very issues that Christopher was just bringing up about, expensive technologies versus more affordable technologies, and how many people are we helping in the designs that we are creating, and thinking about those more structural questions. So it's really useful. So you should check that out.
I will. I was even thinking about this conversation in context to the relationships that we were talking about. Thinking about electronic medical records and the push for that.
Right.
And, I know I'm an occupational therapist and I work in acute care in pediatrics, and I've often experienced this. They expect you to have your note done now, and you have to sit, and they want you to document. But my inclination is to sit and be with the family and talk to them, and support them. And so I just was, curious. I think that is a critical part of this conversation when we talk about relationships and conversation and time. There are all these
and AI could code the conversation better, so we don't have to talk. So that will come too. But then we still have the coding problem. So I keep getting back to that. I hate how are we coding the value of a conversation? It still gets back and irks me a little bit. And then big data will hurt or help us too. Because once we've done more of this coding and we know how to look at that coding quickly, all that does is give billers and coders and insurance companies more ways to try to monetize it. And then on the backside, researchers finally get to try to help and see if it can improve health.
I think I saw Carrie's hand. Oh, go ahead. Sorry.
Oh yeah, I was just going to ask, what are your thoughts about the role of, medication, pharmacology, technology, and mental disabilities? Mental disabilities being something, I guess there is more stigma potentially attached to it. It's kind of harder to diagnose. Arguably. So I'm just wondering, are there any trends that you think are helpful? What's the line between a bit too much versus actually helping?
You want to start?
I would say that, and I don't know anything about particular drugs, so I'll just start with that. But I do know from reading a lot of perspectives of people who are in the CSX movement, consumers, survivors, ex-patients, there's a variety of opinions on the way that people who have gone through the psychiatric system feel about drugs and feel about psychiatric drugs. Some people feel like it helps enormously and they couldn't live without it. Other people feel like those drugs are mind-altering in ways that change who they are as a person, and they just can't, they're just so uncomfortable with it that they can't, live with that. And yet, because medication exists for certain mental disorders, there's a pressure for these people to take them, whether they want to or not. And I think that we have to, be aware of that and recognize that as a source of harm, that kind of peer pressure to take the drugs. So I just wanted to put that perspective on the table. I don't know if you had anything to add.
I think I would agree. I mean, I am not a psychiatrist, but a lot of my children do have other conditions that can contribute to us trying to figure out how their mental status will help us with their plan. But I have my own child has ADHD. I almost refuse to medicate because I am convinced that it will change who he is. And I have had a mother who dealt with depression her whole life, and I felt like every single thing that she tried changed who she was. And kind of think of if you like the rain in Seattle and somehow that helped push your depression, what a much better treatment that would be to just be able to live in Seattle than to take a drug, but you can't sometimes just move. And so I think my answer to your question is there's certainly no one size fits all, and I still worry about the motivations of what mental unnormacy that we would define, especially for some of these other conditions. If it's a condition that creates a dangerous person to other persons, I think it's a little bit more easy for me to think, well, yes, there needs to be something that can help that person still be in society. But outside of that, it's very difficult to me.
I think Atul Gawande talks about this, right? When he's talking about nursing home care and how many of the protocols are not really about patient safety. They're actually about giving the institution more control to routinize things and to make people more compliant and cooperative with the system.
Yeah.
And so I think about, we didn't know ADHD wasn't a thing when I was in elementary school in the 70s and 80s, right? And now every other parent I talk to, I'm a social worker, so every other parent I've talked to in my practice, has got either a teacher or themselves or another parent questioning, does my kid have ADHD, do they have attentional issues, do they have sensory issues? And some of that is because we know more. But some of that is because the school system is overburdened. We have too many kids and too few teachers. And how do we get kids to comply? We have kids with, we know so much more now about learning styles. We have one teacher. And how do we manage that?
Yeah. Did you want to follow up?
Yeah, so my response to that, because I'm an international student, and in the system, I have ADHD as a disorder. And the system I went through the English system, I didn't really feel the pain very much. Partially because of the way we would test it, so the system, the ecosystem. For example, we would be given longer time to perform on tests, and so I never felt that I was much at a disadvantage. I would just have all the time and I'd do well. I come to the States and these symptoms I didn't exactly know what was going on because I was just performing more poorly. And as I reflected, it was because I had less time to do tests, and that was just like a theme that I noticed. So yeah, in terms of the environment, the ecosystem that you're in, and how that impacts, maybe it might also be this time crunch. So I was talking a while ago about very little time between the provider and the patient. It's kind of like a time crunch thing.
Reflection means everything.
Just a comment about technology and mental health issues and also other chronic illnesses. the biggest risk factor in all of medicine is adverse childhood experiences.
Mm-hmm.
And we're spending billions of dollars cleaning up the mess after it already happened when in your first 16 years of life. And if we really wanted to spend money where it was cost effective, we'd be treating adverse childhood experiences and preventing them. And Nadine Burke is a pediatrician in California, gave a great TED talk 5 years ago about the ACE study and resilience. And so yeah, we're spending billions on drugs and all kinds of technology when if we really were going to save money, we'd spend it all on the first years of life.
Yeah.
What do you think would be the best way to, implement these preventative? Because I agree with you a lot. I kind of thought about that. Do you have any thoughts about what good preventative measures, what kinds of strategies, treatment, educational stuff?
Well, preventative measures and changing the nature of the nest that kids grow up in. And so the only thing I'll say quickly on this one is we have something called the social determinants of health, which very simply, back in the social worker realm, it's simple things like, do you feel like you are transportation safe, food secure, that
Human
your
rights.
home is safe?
Yeah.
And we are supposed to feel very confident that those are addressed with every patient, and I never do. And I'm at Duke, to speak to your point of look at around us, and yet I have been at UVA, Duke, I trained at UNC, trained in Charlotte, trained in Pittsburgh. I never feel like I can, without question, feel like their social determinants of health have been addressed. And that is that is proven strategy. Not that I want to always fall back on things that are coded hits, but that's really important stuff. And so I'd much rather infuse money and resources into those sorts of things before starting with brand new paradigms. So.
Yeah, no, I agree with that. I think, like I was trying to say before, it's not just about changing the patient-provider interaction, it's about changing all of the structures and all of the systems that shape patients before they even get to that circumstance. I think Carrie you had your hand up a second ago.
Yeah, so we've talked a lot about disability from the point of view of the patient.
Yeah.
I'd really like some insight into thinking about disability in terms of healthcare workers.
Yeah.
And just think about where that fits into a lot of what we've been talking about, who's excluded, who's facilitated, what the impact of that is.
Yeah.
Great. Well, I'm glad you asked that. That's almost like a plant in the audience. But not at all a plant. So I have been really struck by my colleagues' unwillingness to dive into these worlds with me. And I say that now, again, been really trying to engage dialogue on this for 3 years. And I frequently hit a hard stop because there is so much misunderstanding of that to somehow be a disability advocate in the sense of advocating for neurodiversity, it somehow they feel like it. I have seen again and again, they feel like, well, that's the opposite of what I'm trying to do. I'm trying to eradicate disability.
Yeah.
And when they hear themselves say that, I then go with a follow-up question of, oh, so you want a Ubermensch, you want a perfect human, you are trying to practice eugenics. I mean, you take that down a spectrum and it's not long until you get there. And so until you understand that there's no way that your goal should have ever been to eradicate disability, you can't recenter yourself in how to be a medical provider. And I think that right now we have a real problem with people not wanting to admit that to themselves. I think for them it gets too messy because then they don't have more than 15 minutes. Then they can't just focus on one chief complaint. Then they can't allow 3 different patients to look the same on paper and to have 3 different conversations, because you might need to once you get to know those people better. It gets too messy too quickly. So that's the problem that I'm having, is that I want to have these conversations about reframing, reshifting, because I know none of my colleagues want to practice eugenics, but then they need to re-understand that there's no such thing that's normal, and that you can really focus on certain goals if they're in line with the patient's goals, without giving up the understanding that a person's identity can be very much tied to aspects of disability, and that can be a beautiful thing. And when I even talk to some of the other things, this is not the main problem, but even the most well-meaning people create situations where people feel broken, and I try to go back and re-examine, what are we doing here? So a classic one is motivating children to work harder by threatening them with the consequences. You'll never walk if you don't work harder. You'll never be able to use that left arm if you don't really focus on it after you've had a stroke. And what you're teaching them is, if you fail at this, you will be a failure. Instead of, what great things can we work on, and still know that if you never walk, you're still an amazing person. But we just don't know where we're at right now. We want to keep working on that. And I think that hits hard for some therapists that I work with who say, oh, I never thought I was telling them they were a failure if they don't do this.
Yeah. Okay, at the back?
So, I
Yeah,
guess I'm
that's you.
back.
Yes, sorry.
So, the question is, why would a doctor or a medical practitioner be motivated to work towards advocating for neurodiversity? In other words, is it something in the education and medical school, or is this money issue, or what is driving the doctors or medical world
to limit neurodiversity?
No, to be open to learning about and dialoguing regarding medical diversity. In other words, not an eugenic approach. Why should they even bother? You're an unusual bird.
Yes. I knew that. I would say that's what I'm still trying to figure out by having conversations like this. I'm trying to figure out what is the angle that I can hone in on that seems so obvious to me, to really capture that and take it back into a more effective way of understanding and sharing information. But it's not so different than any other set of rules we have to look at and re-examine when we look at what rights are people, do they deserve. One of the things is that the patients deserve this, so that's why they should care. That's the hard stop. Now, how do I make them care? I don't know yet.
Yeah.
But it's part. Yeah. Well, yeah, and we'll talk maybe about that some more too.
Yeah.
This is a conversation that we've been having. It's a real conversation because neither of us is going to win.
Yeah.
I believe that part of the problem, I'm totally on board. I'm happy with the child that I didn't ruin. And I think he's a great doctor, and I love what you do. But we talk about the language here, and while I know that words mean what we think they mean, they don't mean what the dictionary says. That I understand that. That said, there are differences that we as a society and as a culture understand in terms of what is X and what is Y. And the fact that we don't always know where the line is between X and Y doesn't mean that we don't know where the difference between generally X and Y is. And I say that because your doctors, many of them, when they hear anything from the disability world, they hear things from true believers who are defining the world in ways that are actually linguistically supportable, because really words do mean what we want them to mean. But what they hear when you talk about curative versus therapeutic is a conversation in which it seems like you're saying, if you have strep throat, that you might want to just see what will happen with that, and maybe you'll really like the world that you create by means of having that virus continue to go on to be whatever it can be. Rather than saying, no, that's not what we're talking about. We don't know where the line is between curative and therapeutic, but we know there are certain things that can be cured, and we want to cure them. And we know there's certain things that right now are not, and I mean right now are not curable, because that line between some of those things can get to be curable, and so it changes. But the doctors, if we're going to bring them into these dialogues, and that's a part of what I hope that we will do, if we're going to bring them into these dialogues, then we have to be careful to not do those kinds of world upsetting changes where one minute it is the moon and the next minute it is the sun, and it's whichever one I say it is.
Yeah, I think his question brings up just the extreme level of heterogeneity that there is within the disability movement. You know, whether we've talked a little bit about like mental disability and physical disability. There's all ways of just distinguishing different experiences within this continuum. Some conditions are like temporary or fluctuating, or like you're disabled one day, you might not be disabled another, but it might persist throughout your life. It might be like a chronic condition. And there are so many different ways that that these experiences can fluctuate. And I feel like it's important not to discount anyone's experience just because it might not be the same as someone else's. So while there is like a lot of gray area between different disability experiences and different illness experiences, and there's different ways to determine, does that impact your identity, or is that just something that you're living in for a week? You know, little death is right on that one. Exactly. Yeah. So it actually, I feel like I wanted to kind of continue on the conversation that Carrie started with her question, and just think about it through that lens of power. So she was asking about your specific experiences as a doctor with disability and in these environments. And I think a lot of times, because we see doctors as so powerful and authoritative, that we just imagine them as somehow above it all, that they don't have a body, they're not impacted by illness, they're not impacted by disability. And how does that create an environment in which, you know, there's ableism within medicine itself, like within medical education and training, and to what level are there just assumptions that if you have X condition, you can't become a doctor or you can't become a surgeon, and like what does that do? And on the flip side of that, what would it mean if we had more doctors with disabilities? You know what I mean? What would it mean if we had that level of visibility? And would that help us break down that power differential? Does it help with empathy? If we talk more about the limitations and the fragility of doctors themselves, right?
Yeah, I agree completely with that kind of setup to think about what if 1 in 10 doctors had a known disability that they wanted to advertise as a part of their practice. It would change just having 1 in 10. I use the 1 in 10 model because that kind of shows you that once it's at the 10%, you're like, well, that's a real part of the population. You know, that's an important thing to think about. And obviously disability is much more than that. But if it was even 1 in 10, what you would see
26%.
And what?
It's 26%, according to the CDC just a couple of weeks ago. Yeah.
And that's for permanent disability?
It's, you know what? I didn't read how they were defining it. I think it's just...
And I don't think that you need to define it. I just, what I really want to get at, though, is like you said, it's so rare to see a doctor who will show a clear evidence of a disability. And I think that's one of those things where there's some self-selection that is happening that should not be happening. So I've had friends that are wheelchair users who just that it wasn't worth it. I don't want to have to. I had a hard enough time getting to college to work on my accommodations. I don't want to have to figure out how to get to the hospital. That place is so inaccessible. Again, listen to what we just said. The hospital is so inaccessible, and it is. It is. And so my own experiences have been with. You mentioned that you did training across in the English model, and my own experiences have been, I think if I had done medical school in the UK, I would have been a surgeon, because the way that surgeons train there and the way they focus on their training versus still also having work-life balance, which they do compared to U.S. surgeons, I would have gotten over the fact that I was going to have to make everyone in the OR wear visible masks so I could read their lips, as opposed to the mask that you have to cover your mouth. I went through all of medical school not telling anyone other than the disabilities officer that'd be great if not everyone wore a mask, and everyone did, and I never heard. I had to concentrate 10 times as hard as anyone else to not mess up in the OR and to be able to do it. But I was really good at it once I didn't have to work on hearing people. Wow. And I'm extremely dexterous. I would have had a lot of fun being a surgeon, but it was not going to work for me in what I wanted in my life. So you just kind of think about that. That's on the big scale. A completely deaf doctor who only signs. Mm-hmm. I don't know of a single one, and I'm sure they're out there, but that means their whole practice, it's not, they are going to have an interpreter for anyone that doesn't know sign language, and that's something that should be there, but it's not going to be the norm. I had trouble finding a stethoscope that I could use. It's extremely hard to find a stethoscope for a partially hearing person because they don't work with hearing aids. So, I mean, there's a lot of this kind of thing. Sorry, you had a question. I think I saw two hands. Yeah. Go ahead.
Is it me? I was pre-med. I dropped out. I went to Hamilton College 1,000 years ago. But I didn't know I had a degenerative disease, and I discovered it. But it became very clear very quickly that I would not succeed because there is no accommodation. It's still a struggle in the real world, just daily living of accessibility. But I mean, there are other forms of working in research and science that I would have pursued, but they weren't options. Yeah. They're just not available.
Yeah. There was a recent paper that came out, and we can put it out later, and maybe I shared it with you, that there was a call for more medical professionals with disabilities. Mm-hmm. And to really seek those candidates, to make those candidates feel like that we need you, we want you. The argument that I love about diversity is that it's not some check mark box, it's the name of the game. If you don't have diversity, then you can't play the game in the same way that if you were to try to make a basketball team with all centers, it would be an awful team. It wouldn't be able to do anything compared to a team that has all the different positions of the team. And that's what we're trying to do right now. We don't have a part of our diversity that we need. I think I saw your hand first.
Oh. So a couple thoughts. So one, you were talking about this sort of concept of doctor as superhuman. And I see, you alluded to some of the training, but where at least historically, med residents are expected to work these superhuman hours and continue to have superhuman judgment in the midst of that, and how that deters people with a lot of conditions, even things that happen to everyone, like aging, so it's something that most people would feel much more comfortable doing at 25, but if they're thinking about this at 45, no. Yeah. So that's an interesting thing. I was also thinking about palliative care within medicine and how that kind of is intersecting with what you're talking about as far as abilities and disabilities and what is important for a person, and how that model and intersection could offer some possibilities for everyone, for saying, not that you're necessarily saying, like, let's explore what it would be like to have let's let this trajectory of a sore throat or infection, you know,
Or bleeding artery. Let's just see what happens to that.
But you know, better exploring things like, you know, you're not a problem to solve. You're a whole person. Here are the different pluses and minuses of these different approaches. What way can we evaluate how this can fit into your life to do what's important to you and to make things possible versus doing things to a person.
I thought patient-centered care was supposed to help with that. But so I can only see what I see from the perspective of a patient and of a social worker who works with people with chronic illness and medical crises. But I am curious about where the idea of patient-centered practice comes in during medical training and residency, and what that actually looks like in the culture of a practicing physician.
My only answer to that is that I feel like it was a varnish on a system that still can't take it to heart. Yes, the aspects of being patient-centered are captured when you try to ask someone, what's the best way in which you learn? And so at some point we will ask families that. But we asked it on their MyChart account that they have to have internet to get, that they have to have some sort of a certain level of accessible to the internet to understand that that's where they were supposed to do that. And you know, it doesn't, I don't think it comes through well. Now, again, there are some ways that my personal practice, I feel like we really focus on patient-centered care. But then the flip side of that is that when we're really going the extra mile, I don't have any way to capture, like the lawyer does, the value of what I did monetarily. I'm happy enough capturing what I did without the monetization because I use that part of the system against the system. Because I tell them, I'm going to do what I need to do for each patient, and to the extent that the only thing I worry about is how much I'm making the next patient wait. But that's the luxury that I have fought for because of the nature of the position that I sought. And not every doctor can get to the point of having the power to argue that they have to have that. I have kids with neuromuscular special needs, so I really put my foot down more in a way that others can't. And just on your point, on the back, I don't think I have anything to add necessarily about what palliative care teaches us, except for it flips a little bit of a switch that maybe also gets back to the conversation of all of us in our minds know, even if there's a gray area in something on either side of that area, what kind of feels like, you know, we're looking at anything we want to do is to make life comfortable, to make life, to ease someone's pain and burden. And palliative care, that seems so clear and concrete. And then we get closer into the middle of conditions that are degenerative, that may be progressive, and there's a little bit of that. And then we get to, well, your condition's not progressive, so but you have chronic pain, we can't treat you palliatively. I'm sorry. That's what, you're just a drug seeker at this point. You're someone who is part of the problem of why we're having all these overdoses. Maybe not. Maybe you're a person who needs palliative care in a not traditionally palliative condition. And this is the thing I'll say real quick about doctors trying to figure all this out in the best way they can. One of the things we're getting, my colleagues are getting kind of messed up with in our vision is that we say, this is how you look for drug seekers, and illness identity is a condition that you'll see on Grey's Anatomy with Munchausen by proxy, where they're getting the joy of the attention from having their child or themselves get all this attention through the medical system. And all of a sudden, that's all doctors think all of these behaviors are. And so there's illness identity, and then there's no more disability identity, which can be a very pure positive thing.
Yeah, I'm actually, so you brought up palliative care, and it made me think about some of the hot topics within bioethical debates and what disability studies can offer to those conversations. And I think they often center on beginning of life and end of life. So things like prenatal screenings and to what extent that leads to abortion. And also euthanasia, right? And to what extent a person with a disability might make that choice. And so I think a lot of this centers around quality of life and our ideas, not even just quality of life, but our ideas about quality of life or what we imagine might be the quality of life with a given disability. And disability studies scholars would agree, who's determining that quality of life, right? Whose assumptions about quality of life are we centering these decisions on, right? And where do those assumptions come from? And I think a lot of the times, we think about, we have movies and things that show disability as a tragedy, right? And we have a culture in which it's treated as an individual hardship. It's just your bad luck, right? And rather than seeing it as the thing that makes us human, right? The fact that we are vulnerable and need care. But yeah, I think that if you actually ask the people who have those conditions, more often than not, they report much higher quality of life than a non-disabled person might imagine that they would, right? And so making sure that those perspectives are heard and making sure that the person who's making this decision is making an informed decision that has access to that perspective, because it's often left off the table. Yeah. So that's something I think that disability studies can offer as well.
I'll say about the quality of life.
Yeah.
I frequently have to tell my colleagues who say, I don't believe that a person with a disability truly has a comparable rating of quality of life. And they'll say, I've even seen a study, and I'll go ahead and pull up the study and I'll say, look at what this study is showing. They're studying what is a subset called healthcare related quality of life.
Yeah.
Healthcare related quality of life is in all of our scientific medical journals because that's what we can get published in them. We take none of the literature from overall quality of life in the medical studies. And so we're not even reading that literature, which is what continues to propagate this feeling that someone has a low quality of life. Well, they might report that they don't love having to go to the pharmacy 12 times a year for that one drug that can't be mailed and have to. None of us would like to have to take 12 more trips that other people don't have to take.
Yeah.
But that's a healthcare related quality of life measure, not a quality of life measure.
Yeah. So focusing on the richness of life that is still experienced by people with disabilities, more access to perspectives and stories of people with disabilities, I think could really change the way that healthcare is practiced. I think with that, we have to wrap up. It's about 6:30, so thank you all so much for being here. This was a really delightful conversation. Thank you.
Thank you.